Okay, good evening, ladies and gentlemen, and very happy on the webinar. And today we will have the international conference, or we call the Salon. There is a very beautiful Chinese name. We call the meaning, Chinese pronunciation is 囊括万千. Meaning is the cover everything, especially PTA for cover everything. But tonight we will spend 90 minutes will be specialized for the PAD and from the peripheral artery to AV fistula. This is the concept. First, let me introduce myself. My name is Zhidong Ye. You can call me Dr. Ye. Actually, while working in Beijing, China, Japan, Friendship Hospital, I'm a cardiac vascular surgeon. Means I will open to perform the open heart, or including the TAVR, but most of the cases we perform peripheral artery. And yearly we open nearly 3,000 cases, but the for peripheral artery only 200 cases. And I think the incidence of the PAD will be increasing in China now, and will be with widely same situations. And there is many skills and tools to treat it for complicated PAD. And the balloon is a simple one, but it is it is very necessary. And each professor has his own experience skill, I think. So I think tonight we will have we will invited 6 the speakers. They will share their cases and their knowledge and experience, and we can learn from each other. And together with me, the moderator is from South Korea, Dr. Taegeun Rim. I will invite Professor Rim to have a welcome speech.
Good morning and good evening and good afternoon, everyone, depending on where you are joining us from. My name is Taegeun Lim. I work for the Hana General Hospital. I majored in thoracic and cardiovascular surgery. Cardiovascular surgery. And I hope this session will be informative and meaningful for everyone.
Okay, I will briefly introduce the speakers tonight. First speaker is Professor Jae-Kyu Kim. He is from South Korea. He is the Chuanan University Medical School and the Chief Department of Radiology from the Mongpom Hancock Hospital, South Korea. Maybe my pronunciation, and the speaker will be introduced by yourself. The speaker is from China, Dr. Li Lin, Professor Li Li. He is Associate Chief Physician, Vascular Surgery Center, the affiliate Haichi Hospital of Qingdao University. Qingdao is a very beautiful city. It's near seaside. I'm familiar with Dr. Li Lin. And the next speaker is from Italy, Dr. Andrea Andreone. He is the medical executive in the discipline of radio diagnostic ASOP of Parma from Italy. And another speaker is from Malta, Dr. Kieran Chircop. He is the lead of international radiology of University of Malta. Next is from Taiwan, China, Professor Zhang Weijun. He is the attending physician of Fengyuan Hospital. And the next is from Brazil. One is Dr. Calos Barros. The other is Dr. Felipe Calos. They all them from Brazil. Well, welcome to join this webinar, and I will open our session. So I will introduce the first speaker from Jae-Kyu Kim. The topic him is the recent experiences of scoring balloon. Welcome.
Okay, good morning, everybody. Good morning, afternoon, and good evening. So from the west to east, I'm Jae-Kyu Kim. I'm interventional radiologist and the Mokpo Hanguk General Hospital. The Mokpo is some kind of harbor city. So my topic is recent experiences of scoring balloon catheter in the PAD. The first case, a 50 years old male, his chief complaint was a right leg claudication for 4 years, some intermittent claudications. So at the local hospital, he diagnosis just like Buerger's disease, but anyway, he has a diabetes and hypertension. And also he is a Navy officer. So you can see in this CT angiogram, it's so fast. Okay, I will turn it more slowly. So you can see the right common iliac artery is okay. Right external iliac artery is okay. But from the just orifice of right SFA, the total occlusion was noted to the distal SFA. So you can see here, you can very long lesion, and also you can see the rich collaterals from the deep femoral to the popliteal arteries. That means it's a kind of chronic disease. In angiogram, you can see also just like a CT angiogram, the lesion length is 25 centimeter. So I tried to re-enter just like access from the orifice of SFA to the distal lesion. I use the CXI and the PT2 guide wire. I tried to several times, but when I introduce the CXI supporting catheter and guide wire, there's no resistance, very smoothly pass. On the CT, you can see there's no calcification and no arteriomatous plaque such as. So what is the treatment option? The PAD, but it's some questionable long-term patency because his age is too young. Lacerectomy is one of the kind of method, but there is no arteriomatous plaque for cutting. So next is the stenting, but he's too young, and also he's a Navy officer. So stent is not indicated for him. So I choose some kind of nothing behind. So last option is DCB after vessel preparation. So I choose some Castor balloon catheter. It's a small, just like actually, this case is my first case with tri-edge scoring balloon. So I use the pre-dilatation with the Castor balloon. The balloon is a 2.5 by 150. So you can see here, it's very long balloon. This one is just a preparation, not actually preparation, just the first dilatation, small caliber balloon. This was the proximal SFA, this mid to distal SFA. After that, I chose the scoring balloon, 5 by 6 millimeter. So you can see here, this is just before the dilation. This one is during the dilation, mid from the distal, mid, and the proximal. And as you know, this balloon is very unique balloon. There's three wire is the 150 scoring element, and the balloon catheter is a non-compliance. So I choose the 6 millimeter. And as you know, the Tri-Wedge operation instruction, I just follow this instruction. So I dilate with the nominal pressure to all 15 atm. So this is the final angiogram after the scoring balloon angioplasty. You can see here very smooth lumen gaining, but at the distal SFA, just like intimal dissection, but it's not true. So I dilate with the scoring balloon again, and I choose the next option, the DCB, 5 120 and the 2, and the 5 to 100, just 1. So you can see here, after DCB balloon angioplasty, you can see here the good luminal gaining from the whole SFA and also distal popliteal and below Lin Li arteries. This one is the ABI check. This one is in the pre-treatment. You can see here the systolic is the 85 and the diastolic is the 53. But after treatment, you can see here 120 to 74. And his symptom was very improved. And just yesterday, I called him, how's it good? And he felt very, very happy with these procedures. And he's very, very satisfied. And also as I told you, he's a Navy officer. It's very, very important for him, just operation or the other stenting. But I see it in the DCB with the scoring balloon angioplasty is the best option for him. And this one is the second case, 84 years male. His chief complaint was he had a left femur fracture and the fin fixation, and he is bedridden state, and also both calf bed sore and cholangitis. And this one is a CT angiogram. You can see here both SFA is occluded. Actually, this right side is more long than the left. The left looks like very short. You can see that this left I treated with the stenting after the angioplasty, but I used the left SFA lesion. I'm trying to use the scoring balloon. So this is my second case. The angiogram shows, it looks like very short, but you can see there's some luminary irregularity here. It's very easy to get re-entry from the distal, but the actual situation is not. I'm trying to several times to see some supporting catheter and guide wire, but it's not success. So I punctured in the distal SFA and trying to retrograde approach to the above, but trying, but it's not successful. Some intimal dissection for here from the below. So I use in the reverse cart technique and the balloon dilation and the cannulation from the below, and I can make the loop technique, and I can cannulate the catheter. You can see here, and I use in the scoring balloon 5 by 6 millimeter. This is scoring balloon, and this one. And I use in the self-expandable stent 5 by 220. And this one is the final angiogram. It's very good angiographically. And during the dilation in the 2 cases, I ask to the patient, did you feel any discomfort or pain? But the 2 patient has, it's good, no pain. So this one is the pre-ABI. You can see the left is 0.7, but the post-angioplasty, the 0.8. So the ABI is improved, and I'm waiting the wound healing. So this is the last case. And the third case, actually, I do procedures yesterday. So this one is not some burning case, very hot case. The 78 years of male in both leg, claudication from 4 months, hypertension, diabetes mellitus, hyperlipidemia, And actually, he treated 2021 December, both iliac artery stenting and both SFA PTA, but he complained again, and this one is a follow. You can see here heavy calcification in the both common iliac artery and external iliac artery, and also both SFA orifice is very heavy calcification. Is the lumen is very, very narrowing. Looks like some flush occlusion. So heavy calcification during the both SFA. And this one is a radiogram. You can see here some just like a tremor-like, some heavy calcification from the common femoral and SFA. This one angiogram, you can see here, common femoral artery shows multiple severe stenosis, and also some distal SFA, also some severe stenosis. ATA is long occlusion, and the PTA, the proximal PTA is some stenosis. So I do in the colon scoring balloon angioplasty serially from the distal to the common femoral artery. And I use in the DCB 5 by 150 from the distal and mid and cover the whole common femoral artery. So this is the final angiogram. You can see here the lumen gain is good, but you can see here the deep femoral artery, and I do also in the angioplasty here after the scoring balloon angioplasty. And the distal SFA also is wide lumen gaining. And also I asked this morning to the patient, he felt very good. And he get some warming sensation in his right leg. So I waiting for him. There's a good result. And this one is a kind of some reference from this one from Korea. Some predictive factors to severe dissection after POVA and the PEMPAP arterial disease, the long lesion and occlusion, and more than 70% of stenosis. Is some independent predictive factors in the severe dissection. So the severe calcification and using scoring balloon appears to be the protective factors against the severe dissection. And this one is also another one. And this final conclusion is better initial restoration, the best lumen, providing high efficacy. For the following the angioplasty, we said the cutting balloon. But they use some basket track, some scoring balloon, the chocolate scoring balloon, and this one also another reference. And he is also some basket track. But anyway, the scoring balloon angioplasty reduce the incidence of severe dissection and overall the stenting implant rate, and also the rate of the spot implant, DS implantation. So I would like to conclude my presentation. Scoring balloon dilatation, the Tri-Wedge Brosmed, can be used for the vessel preparation for the DCB very, very effectively. And also, the scoring balloon dilatation catheter is a good tool for vessel preparation of heavily calcified artery for next treatment, such as DCB or stenting. Thank you for your listening.
Thank you very much, Jae-Kyu Kim. Excellent cases. We should have 1 minute left for discussion. Is there any questions for Dr. Kim? Actually, 3 cases is, especially the last 2, is real in China. Is old age, severe calcified. And my question is for second cases, you using scoring Tri-Wedge balloon, but still, finally you use a stent. So what is the indication for stent using?
I use the self-expandable stenting is some Protesi, the self-expandable stenting, and I'm just worrying about some recurrence of, because he has a bad renal state and also some bad sore the both calf. So I'd like to more increase the blood flow to wound healing. But if he has some claudication, just like the first case and the last case, I like using the DCB balloon rather than stenting. Yes.
Okay, for the first case, the length is the largest one compared with the other two. But from the proximal and the distal runoff, we think the first one is relatively easy for recanalize, but actually intraluminal recanalize. And do you think there is a possibility there is a thrombus in the occlusion segment for the first case?
Yeah, and you can see the make a plan. I just evaluated the CT angiogram. You can see the whole SFA lesion is collapsed. There's no thrombus. So I'm just wondering how this long segment is that there's no arteriomatous occlusion or any some thrombosis. And I'm just still wondering. So you have any experience just like this? Please recommend me or just give me some help and a good recommendation.
Okay, thank you. Because of the time, I will invite Professor Rim to introduce the next speaker. Would you please?
Thank you for a nice presentation, Dr. Kim. And
Dr. Rim, you open. Yes.
Can you hear me?
But now we can hear you now. Mute again.
This topic is application of case sharing of Tri-Wedge scoring balloon in lower extremity arterial disease.
Okay, so thank you for the introduction. Good evening, everyone. I'm Lin Li from China. And tonight, my topic is application and case sharing of the Tri-Wedge scoring balloon in lower extremity arterial disease, focusing on Femoro-Popliteal artery lesions. As we know, the endovascular therapy of lower limb arteries has undergone a transformation from POBA environmental stent to drug delivery, divorce, and debulking, which has greatly improved the bleeding patency and reduced the use of stent. So the change of concept has put forward a higher requirement for vessel preparation. So its goal is to create an optimal environment for angioplasty. A good vessel preparation can improve vessel compliance, increase the luminal gain, facilitate drug distribution, and minimize the adverse events such as dissection, embolization, and perforation. It can also decrease the need for stenting. So the vessel preparation methods include POBA and specialty balloon, include scoring, cutting, chocolate balloon, and central. Of course, atherectomy is a good method. We can do the directional, rotational, laser, and optical atherectomy. If there are thrombus in the lumen, we can do PMT and CDT to remove the thrombus. For the median calcification lesion, the intravascular lithotripsy is a good option. There are some other methods, such as the pave and crack technique. So there are so many kinds of scoring balloon in the world, but the mechanism are basically similar. So the balloon catheter with protruding elements well placed attached to its surface. It can score or incise the plaque buildup in the artery during inflation, which helps modify the plaque, make it easier to dilate the artery and prepare for further treatment. So the benefits of scoring balloon is it can enhance lesion preparation, improve lumen gain, reduce the restenosis and dissection. In the future, it will have a favorite outcome. So it can use in the lower limb endovascular therapy. It can use in the situation of some calcified lesions, instant restenosis, and complex lesions. Of course, it can also used in conjunction with the drug-coated balloon. So let's say the case. The first case is 84 years old female patient, and his foot has a left foot ulceration for 4 months. The risk factor is diabetic mellitus, hypertension, hemodialysis. The ABI left is 0.2. Diagnosis ASO, look for classification 5. So from the CT angiography, you can see that the lesion is located at the left SFA and popliteal artery. So the procedure we plan to do is from the right confirmatory approach. And for the SFA, we decided to do the PTA and stenting implantation. And for the popliteal artery, we decided to do the scoring balloon dilatation. So this is the baseline angiography. We can see that there is a long total gluten in the proximal SFA, and there are some moderate to severe stenosis in the popliteal artery P1 segment. And for the runoff, there is only a ATA. So the wire passed the lesion easily. And first, we use the 4 millimeter balloon to pre-dilate. We can see the notch point during balloon inflation. So for the distal SFA and the P1 segment, we use the 5x60 Tri-Wedge balloon to avoid flow-limiting dissection. This is the process. So post-dilatation angiography show that the blood flow is good. And so we use the 5 millimeter drug-coated balloon to dilate the lesion. But there is a severe stenosis in the proximal SFA, but the distal and the popliteal is good. So we placed a 5 millimeter by 150 millimeter stent here and used the 5 millimeter balloon to post-dilate. So this is the final angiography. So the second case is a 74 years old male patient, and the chief complaint is weakness in both lower extremities for 5 years, left foot pain for 20 days. Risk factor is hypertension. ABI left is 0.4. Sorry. Diagnosis is ASO root 4 classification 4. So this is the CT angiography. We can see that the lesion is located at the distal SFA and popliteal artery. So the procedure we plan to do is the right confirmatory approach, and we decided to do the directional atherectomy combined with scoring balloon and drug-coated balloon. So this is the baseline angiography. We can see that there are some severity mild stenosis in the iliac artery, and the lesion is here from the distal SFA and P1 segment. The runoff is only one anterior tibial artery. So first, we placed a Nev6 filter in the P3 segment, and we use the Tomahawk to do the atherectomy. This is the process. So post the atherectomy, we can see the luminal gain is good. So we used the 5x60 Tri-Wedge balloon to avoid flow-limiting dissection, and this is the cost. So post-dilatation, this is the angiography. And we use the 5x200 drug-coated balloon dilated lesion. This is the final angiography. I think the blood flow is good. So this is the plank we cut. The third case is a 74 years old male patient, and the chief complaint is weakness in both lower extremities for 6 months, ulceration or big torn on the left foot for 1 month. Risk factor is diabetic mellitus and hemodialysis. The ABI left is 0.2. Diagnosed is ASO root classification 5. And this is the CT angiography. We can see some thrombus in the aorta. And in the left external iliac artery, there is a severe stenosis. And there's some long stenosis and a occluded lesion in the SFA and popliteal artery. So the procedure we plan to do is the crossover approach. And for the iliac artery, we place the stent. And for the SFA and popliteal artery, we decided to do the directional atherectomy combined with scoring balloon and drug-coated balloon. So this is the baseline angiography. We can see that there is a severe stenosis in the external iliac artery. So we used the 4 millimeter balloon to pre-dilate. Then we placed 8 French sheath crossover sheath, and we do the SFA and the popliteal artery angiography. This is, we can see the lesion. And for the P3 segment, there is a short occluded lesion. So we use the Asaki Gladius 18 wire to pass the lesion. This is the process. We can see that the wire succeed in passing the lesion. So we use the 2.5 millimeter balloon to pre-dilate, and then we placed a spider filter in the TP trunk. So this is the process. So this is a 5 millimeter filter. And we use the tomahawk to do the directional atherectomy. And post the atherectomy, you can see that the luminal gain is good. But for the P3 segment, due to the safety distance, we can't do the atherectomy. So we use the 5x60 Tri-Wedge balloon to dilate the P3 segment and use the 5x200 drug-coated balloon to dilate the distal SFA and popliteal artery. So this is the angiography. We can see that the blood flow is good. So we use the guiding catheter 6 French to remove the filter. So this is the plunk we cut. For the below the knee, there is a occluded anterior tibial artery. Due to the ulceration is located at the first big toe, so we decided to dilate the anterior tibial artery and the dorsal penis artery. And the wire passed the lesion, so we used the 2.5 for the distal and the 3 millimeter balloon for the proximal. So this is the final angiography. We can see that the blood flow is good, and the contrast can raise into the distal of the big toe. So for the external iliac artery, place the 7 millimeter stent here. So take-home message: the 3 triangular design metallic scoring elements of this balloon provide more concentration and less slippage on the vascular wall to effectively modify fibrous and calcified plunk. In our experience, Tri-Wedge balloon can effectively reduce the occurrence probability of elastic recoil and residual stenosis in Femoro-Popliteal artery lesions, and also reduce the formation of low-limiting dissection. The combined use of atherectomy and drug-coated balloon have better results. In future, more clinical studies are still needed to confirm its efficacy and safety. Okay, that's all. Thank you for your attention.
Thank you for your nice presentation. There is something different other ways.
Dr. Rim, you mute again.
Can you hear me?
Now it's okay now.
Thank you for your nice presentation, and I'd like to ask to you, what's the choice of integrated or contralateral approach?
Sorry?
Usually using the integrated approach to perform the directional thrombectomy or something, but almost all patients you did through the right common femoral artery. It means the contralateral approach is much more easier, or what's the choice criteria of integrated or contralateral approach?
Yeah, we often use the 7 French control set. Maybe when we use the drug-coated balloon, we use the 8 French, so it can cross the teeth easily.
May I ask a question?
Okay.
Hello, nice to meet you.
Nice to meet you.
How long do you perform the dilatation with the scoring balloon? Like any other POBA, or longer or shorter? I mean, 2 minutes, 3 minutes, 1 minute?
If I decided to do the scoring balloon for the last balloon, maybe we dilate it for 3 minutes. If we pre-dilate, we want to use the drug-coated balloon. We dilate it for 1 minute.
Okay. And wouldn't you be happy with longer scoring balloons? Because I saw that you always used really long DCB. Of course, the lesion was really long. So you used the scoring balloon only in a small part of the vessel, or you did the dilatation of the whole vessel with the 6 centimeter balloon that takes quite a while?
Yeah, because in our hospital we don't have long scoring balloon. We only have this 60 balloon.
Okay, thank you.
Yes, in the interest of time, let's move on to the next speaker. Next
Okay.
speaker introduce Dr.
Okay, let me introduce the next speaker, Dr. Andrea Andreone. He's from Italy. He will talk about from the peripheral artery to the AV fistula, real-world cases with Castor, Achilles, and Tri-Wedge. Welcome.
Hello, nice to meet you. Let me know if you can see the presentation. Can you see it?
Yes, but you should.
Just now, yes.
Yes, just now, yes. Okay.
Okay. So just a brief introduction. We are 3 interventional radiologists and 3 interventional neuroradiologists in the Parma hospital. Parma is between Milan and Bologna in the northern part of Italy. And this is our activity in the last years. So we perform a lot of PTA in peripheral artery disease and also in dialysis fistula maintenance. So this is the first patient, is another woman, 87 years old, with type 2 diabetes, with R5 left leg lesion. This is the angiography. As you can see, she has a really long and calcified occlusion of the Femoro-Popliteal segment with effective recanalization only, as you can see here, at the level of the, well, P3 next to tibial arteries. And she has good tibial perfusion also in the foot. And so we started, of course, antegrade from the homolateral axis, but there was no chance to go intraluminal or to go through this really long lesion. So at some point we decided to go retrograde. We decided to make an access in the peroneal artery because it's actually quite easy to do it because you just put the artery between the bones and you go straight with your needle. And as you can see here, the puncture is quite effective and also safe. There is some literature about it. So we went to retrograde with an 018 wire, and we did the rendezvous at this level, which is always something that is really satisfactory when your wires and catheters meet. And so we performed predilation with this is a Castor catheter, a 3 millimeter Castor catheter, really long. And after the predilation, this is the result. Of course, this is a subintimal recanalization. There was no chance to go intraluminal. So we decided to go on and complete the reperfusion. This is another angioplasty. On the right one, there is a 5 by 150 millimeters Achilles balloon. And after that, there is good recanalization. In this case, it's when we create a new road that it was not present before. We always put a stent and She was 87 years old, so this was our best, our choice for the best of the patient. This is a supera stent in the popliteal region. And also we put another more proximal and also a drug-eluting stent that from Cook, Zero PTX, post-dilated up to... Sono impegnato! I'm sorry. People keep knocking. And this is the final result in the Femoro-Popliteal region and in the tibial arteries. So this is the material that we used. So a short review. This is the second patient, 78 years old, with hypertension with an R5 on the left leg with severe rest pain. We went from the contralateral approach because the occlusion was from the very beginning of the superficial femoral artery. So this is the angiography. In here you can see that also this patient had a really long occlusion with heavily calcified arteries. And this is the periphery, where also the tibial arteries were quite ill, quite calcified. With the later recanalization of ATA, and the foot is you can see that ATA is the only vessel. So our target was to have an antegrade flow to ATA. So we started from above, started recanalizing it. Also in this case, it was not possible to go intraluminal because the occlusion was too long, too calcified. And step by step, we had some progression of the wire with some fistulas with the vein that is quite common in these cases. So here we are in the popliteal region, but still a lot of work to do. We decided to predilate. This is an 018 wire, so this is an Achilles balloon. This is the dilatation of the artery. So now we are close to the goal, but still a really diseased distal popliteal artery. We could go inside the peroneal artery, but it was not possible to go to cross the calcified lesion of the ostium of ATA. So first of all, we recreated a flow up to the tibioperoneal trunk. This is the balloon working in the femoral region. Here also we started putting some stents in order to maintain a proper lumen. This is the flow. As you can see, there is still a really heavily diseased distal popliteal artery with a really tight stenosis of the ATA. I'm sorry. It's not moving anymore. Okay, so after this, we really wanted to recanalize this anterior tibial artery because the flow in the foot is not enough from the tibioperoneal trunk. So we decided to go retrograde in ATA. And we did successfully cross the lesion. We put, this is a Castor balloon, 3x40. This is the dilatation. A really heavily diseased popliteal artery, so we decided to put a stent here also. This is a supera stent. And this is the final result on the foot. That is quite satisfactory. So this is what we used. This is just a brief, what I like about Castor and Achilles. Well, they have a really wide range of sizes from caliber, from diameter up to the extension of the balloon. Very high pressure balloon that are non-compliant, which in vessel preparation, I think that nowadays is mandatory because we need to prepare the vessel without hurting it. So non-compliant balloon are a really good choice, and a really good deliverability because they have a coating that allows really good deliverability of the balloon to your lesion. So this is the last case. It's an AV fistula of a 65 years old patient with 3 days a week dialysis. This is the first stenosis. This is my first experience with the Tri-Wedge balloon. So this is the distal radiocephalic fistula. As you can see, there is a tight stenosis. This is the Tri-Wedge at low inflation pressure, like 4 atmosphere, as suggested by the by Brosmed, and this is higher inflation. And this is the result with a good result and no stenosis left. We wanted to also take care of the arterial side because it looks a bit problematic. So we went through it with an 014 wire, and we tried to put a drug-coated balloon immediately as first choice, but it was not possible. And the only thing that went through was this Castor balloon that we expanded, and that gave us a good result, as you can see here, and also a really good deliverability of the Castor balloon and the Tri-Wedge balloon. So this is the material we used. Also drug-coated balloon after predilation. So this is just a brief review of the Tri-Wedge balloon, which is has this triangular shape that gives the longitudinal triangular shape that gives a really good vessel dilatation with a really small incidence of dissection and vascular problems. It's also a non-compliant balloon that is really mandatory, and I find it really useful, as I commented before, especially in AV fistulas. 60 millimeters, if I may have given us an observation, is a little bit short in the peripheral arterial disease, where sometimes you need really long balloons in order to treat like the Femoro-Popliteal segment. So in conclusion, as we know, vessel preparation is really mandatory nowadays, and debulking is one option, but I don't think that we can do it in every patient, also for costs that are really high. So in order to have my first choice in vessel preparation nowadays is non-compliant balloons and scoring balloons, and after that drug-eluting beads. These balloons have really high deliverability and trackability. And in AVF, I think that scoring balloons are really, really useful. Also for first stenosis, but also in late stenosis, like the third treatment. After that, we sometimes put stents, like supera stents, also in AVF. And I really think that vessel preparation also in the dialytic fistula are very important and mandatory. Thank you.
Thank you very much for the Andreone. Give us excellent cases. This is really really challenging case for the first two. For the PTA, it's a very long segment occlusion from the beginning of the SFA to the TB trunk, and the very severe calcified total occluded. So your technical is good. And I think I do agree with your idea about the Tri-Wedge, the scoring balloon. I think Tri-Wedge scoring balloon give us very excellent job. For my question is, I noticed that these two cases, for first two cases, you didn't use the atherectomy, but the result was very satisfying. Do you think the Tri-Wedge balloon has a key point for that?
Well, I didn't use a atherectomy because it was subintimal. So when we go subintimal, usually we don't perform atherectomies. And the scoring balloon might have helped, yes, but actually, to be honest, I didn't have it in my cath lab. And another thing is that if you have 30 centimeters of occlusion, 2 minutes, 3 minutes for every dilatation for 6 centimeters takes quite a lot. So I think I find more useful to have long non-compliant balloons that in just one dilatation I fix everything, or kind of, because this procedure, as you can think, took a lot of time, and also the patient are old. They have a limited time of working time for us. After that, they start getting a little bit mad. So.
Okay, yes, I do agree with you. And I think using the atherectomy should be intraluminal, but the long CTO always go into subintimal. So my question is, in your experience, for the first and second lung cases, how many percentage successfully with
Working time for us after that? I'm sorry, I lost the final part.
So in the long CTO, you can sometimes it's difficult for intraluminal recanalized. Most of the cases, for example, 70% of the cases will be go subintimal. What's your experience? How many percentage of go by the intraluminal way?
Well, it depends. It depends a lot on the plaque anatomy, how the plaque is done, because sometimes you go extraluminal. As you start, you are already extraluminal. In this case, sometimes maybe it's better to go retrograde when you don't see too much calcium, but after you try antegrade, you already know that you are extraluminal. Sometimes going retrograde keeps you intraluminal more easily, because the distal part of the occlusion usually is softer than the proximal, that is usually harder, and sometimes it just takes you out of the road that you would like to keep. So anyway, when there is a lot of calcium, I really think that is just chances. 25 centimeters of calcific occlusion. When you go intraluminal, you are lucky, in my opinion. Not, I don't think that there is some special skills that keeps you in the lumen with a lot of calcium.
Okay, thank you. Well, I will, Dr. Rim, could you introduce the next speaker?
Yes, and now we have two, Chircop from Malta, presentation for tailored for PTA success, Minerva and Polux success, vascular territories.
Good evening, everyone. Let me share my screen. Can you please confirm that you're seeing my screen? Is it visible?
Yes, we can see you.
Okay, good. So I'm an intervention radiologist. I work in Malta, which is a small island below Italy, Sicily specifically. We are one hospital to cater for the needs of our population. So everything comes to us. Our department is made up of 2 angio suites and around 4 intervention radiologists and 2 neuro radiologists. These are my disclosures. So what will I be talking about? Well, in today's world, the stores are not infinite, the money is never enough, equipment is expensive. So I will be talking about how we manage to take care of our patients using simple things by applying, for example, in this particular case, the angioplasty balloons in multiple situations, in multiple scenarios across the whole body. We look at some characteristics of the balloons, which make them very good for our use, and we'll also share several cases as we go along. Let's start. So the PTA, as we all know, it's not the final step, but it's often the first. And as everyone correctly said, vessel preparation is a pillar of getting a good result. And having the right tools is always very important. And you can rely, if you have a good balloon on which you can rely, you can rest assured that you will have a good day in angio suite. So we predominantly have the Minerva platform and the Polux platform. What I like about them is their big range of sizes and lengths. The material is very good, their kink resistance. We use semi-compliant, so a little bit different from our Italian colleague. We find that the semi-compliant give us the best of both worlds, let's put it that way. Sheet compatibility is good. Most of the procedures we can do from a 5 or a 6 French sheet. We also have the Polux platform, which is an 014 platform, and usually we leave them either when disease gets very, very tight or to go around the plantar arch. Okay, so starting off with a case, for example, here we have a Rutherford 4 patient with a very tight stenosis in the SFA. Most of our patients have ulcers because of a large incidence of diabetes and smoking in our population. So here you could say, I can go subintimal, it's short, but if you go luminal, your result will be better. So using a straight 018 wire, a bit of care, you will cross that lesion. Very simply, we use the Minerva balloon here, 5x4, and the gentle inflation helps you to prevent dissections. The short length helps you to avoid damage to the rest of the vessel, which was pretty okay. Despite all efforts, so the gentle inflation, etc., sometimes the sections do happen, and you need to have some stents off the shelf. And in this case, we just put a spot stent in that segment, leading to a good result. We weren't happy because the patient had an ulcer in the angiosome supplied by the anterior tibial. And as you can see, there was a very long occlusion of the anterior tibial artery, which recanalized just above the ankle. Again, went with a wire, straight 014 wire, and we crossed the lesion luminally, and we used a long Polux balloon. Why? The longer the balloon, the lesser the incidence of dissections, the more controlled your inflation is. And as it was mentioned before, our patients only give you an hour at most to do most things, so otherwise they get very irritated, especially since we work only under local anesthetic for 90% plus of our procedures. And as you can see, simple prolonged angioplasty gave us a very good technical result. The patient still had a PT and a peroneal, but now we opened up the flow to the ulcer area as well. So nothing fancy, just simple, plain old balloon angioplasty. You can use a drug-eluting balloon as well to consolidate further, but we deem this to be enough. So going again to slightly more complicated case. So this was a patient, high BMI, smoker, had a Fem-Pop bypass, which was diseased here at the origin, you can see, and had disease also into the single vessel runoff, the AT. The AT had a distal occlusion, but we said, let's try to open up this very narrow peroneal, which, as you can see from the original image, it was a fair vessel. Put in a 6 French sheet down to the popliteal artery, allowing us to put 2 wires. So the nice thing of the Minerva, for example, here, the 3 millimeters, I could leave the 2 wires inside, always preserving the channel and doing alternating balloon inflations. Did the balloon inflations and ended up with a result that looked very good like this. We decided to stent eventually this segment because at a later stage it recoiled a little bit, used the 3 millimeter below the knee stent. But here the property that was most convenient for us, we had good sized balloons, longer, and through a 6 French sheet I could keep a body wire keeping access to both vessels and crossing this lesion with the balloon, and because of the very low profile, was very, very easy. The AT was tackled again, as you can see here, with a simple prolonged balloon angioplasty, giving a very fair result with good reperfusion of the foot. Fistula, so this would be your conventional radiocephalic fistula, tight stenosis at the very edge of the anastomosis here. Again, crossed with a wire, simple balloon angioplasty, giving a good result. Now, a little tip for the younger members of the audience. These are very, very painful. Dilatation of the radiocephalic fistula is very, very painful. What we found to be very, very effective is before you start the procedure, do an ultrasound and inject local anesthetic all around that area. By the time you cross it and you come to dilate it, the local anesthetic has worked, and basically it will be a pain-free procedure. All this was done through a 4 French sheet access, so very, very non-invasive, literally an outpatient's procedure. And the Tri-Wedge, so the Tri-Wedge came after I did that case, unfortunately, for me. We've seen the very nice outcomes and everything. I believe the technology is good. As you can see, it gives us a controlled dissection, let's put it that way, of the disease, leading up to a very controlled tear in the intima rather than like an explosion. And the very good thing is we found that it has a very good navigatability across the angles, especially these radiocephalic fistulas tend to be very tight angled usually. So I'll show you a case here. It was a very simple brachiocephalic fistula with high pressures here. And you can see very tight stenosis. We know that these tend to be very fibrotic over here. So using conventional balloon would probably still have given us a good picture, but the long-term outcome would have been less ideal. So we went straight for the Tri-Wedge balloon, and you can see here the image before we did a consolidation treatment with a drug-eluting balloon. But you can see we used only 6 atmospheres to dilate this, painless, very, very good result. Flow dynamics are very good. The check after 4 weeks, this is doing great. Now going out of the conventional, this is where we had to use our thinking hat, put on our thinking hat. I was presented with a patient that had pulmonary vein stenosis. You can see the superior and the inferior pulmonary veins here. They are very stenotic. You can see a large pleural effusion. And this happened after the patient had a cardiac ablation for atrial fibrillation. It is a known complication, but it is extremely rare. This patient got two pulmonary vein stenosis. And he was a cyclist, so couldn't really continue. So we decided to do something for him. So gained the transseptal access using transesophageal echo as our guidance. once you get the steerable sheet into the atrium, you cross the stenotic pulmonary vein, leaving wires inside. Now, the bigger the hole you make, the bigger the atrial septal defect you are committed to. So in this case, we managed to get a 7 French sheet across, and using the Minerva 10 by 2, so we managed to do both pulmonary veins through the same sheet, keeping wire access across both sides. The result was good. Did not need to enlarge the sheet, unfortunately, but the patient recurred after 16 weeks. So we had a good initial result, but the patient came back with the same symptoms. We did exactly the same procedure, but this time after the dilatation, we implanted bare metal stents. And as you can see here, with a very good results as well. Again, did the same procedure, just implanted stents afterwards. Result was good, did not need to buy any fancy balloons, did not need to buy anything particular, use the same equipment, getting things done. We do aortas, and sometimes we need to flare stents, reflare stents. For example, this patient had a large thoraco-abdominal aneurysm with 4 vessel fenestrations, had an endoleak from the left renal artery. You can see here the flaring wasn't done great. This is the edge of the aneurysm. Very simple, use the 6 French sheet, a Minerva 10 by 2 from a brachial access, flared it very nicely, so didn't need to buy any new fancy thing, using our baseline platform. And as you can see now, the flaring is so much better, with complete resolution of that endoleak by a simple 6 French brachial access. Let's go on to more weird things where you need to become a little bit, you might need to buy some things, or you need to be a little bit more ingenious with your equipment. So there's a patient with a thoraco-abdominal aneurysm. As you can see, it goes down all the way to the celiac. Symptomatic patient. Unfortunately, the gastroduodenal plane and anastomosis was atrophic, so sacrificing that celiac access was deemed to be too risky. So we had to invent something. Now, if you go back to the image here, the SMA was good, but no one would get us a designed stent graft for that. So we decided to do it ourselves in theater. So this is the aneurysm here, deployed a stent into the celiac, a covered stent, used a steerable sheet and the re-entry device, 018 wire, crossed the fabric of the stent graft. A Minerva balloon was easily pushed through, dilated, pushed a bigger balloon through, again another Minerva, this is a 6 millimeter balloon, and through that defect in the fabric, then we implanted another bridging covered stent. I can show you the result here. So this looks very, very good. We also use the same balloons to do the flaring, and as you can see here, the flaring before and after the stent graft is very good, leading to a very good seal with a happy patient. Going down to the lower limbs, as I said, this is a very common case for us. We have extensive atherosclerotic disease. This was a 72-year-old diabetic patient with a complete iliac occlusion, not fit for a haircut, as we say here, having rest pain onto the legs, so bilateral common femoral access, pigtail angiography to outline the occlusion, puncture under ultrasound guidance of the other common femoral, marking the origin of the artery of the collaterals and the puncture site, subintimal recanalization. Using a re-entry device, we re-entered into the aorta using a very long Minerva balloon that tracked easily through the very, very long CTO. We dilated the tract, so one balloon, one dilation, placed stents, did a pigtail run. We were out of Dodge in half an hour. We used bare metal stents over here to preserve the collaterals. could have used the cover stent above here, but given the age and the multiple comorbidities, we said it will not make a big difference in the long term. We had very good flow all the way down the leg. The patient was happy. Take-home messages from my end, from a small hospital that has to deal with everything that comes through the door. Simple balloon angioplasty is a foundation of the department. It's not optional, so make sure to choose a good platform that will give you all the options to treat both the conventional disease, but also the unconventional disease. I showed you some unconventional disease. These cases are not common, but they will happen to everyone. One platform, if it's a good system like we have, can be used across several territories, and the success at the end of the day depends on how well you can adapt, and knowing the advantages and limitations of your system will help you adapt to what the hospital shoots at you. Thank you for your attention. I'll be happy to answer any questions if there are any.
Thank you for a nice presentation, and it's wonderful and successful and incredible results you show us from aorta disorder to the AV Fistula. To stay on schedule.
As I said, the adaptability, using one platform to do many things, that keeps you dynamic.
Yes, it's incredible. So to stay on schedule, we'll now continue with the next presenter.
Okay, next presenter is yes. Next presenter is Jun from Taiwan, China. He will talk about the low profile access for PAD. Because of time, I think please, Dr. Rim, you can invite the last speakers.
Yes, now we welcome Dr. Barros from Brazil. Presentation about optimizing peripheral endovascular outcome. Please, Dr. Barros.
Good evening, everyone. Everyone can hear me?
Yes, we can hear you. We can hear and see you.
Okay. So, my name is Felipe Barros. I'm a vascular surgeon and the vascular surgeon here in Rio de Janeiro, Brazil. And today I will share my experience with Tri-Wedge scoring balloon and the Teach high pressure balloon. My disclosure. As we all know, this is the workflow that every endovascular surgeon needs to keep in mind when they're dealing with angioplasty. And in my view, the vessel preparations is the really key for achieving good outcomes. And when we are thinking in vessel preparation, the atherectomy is the first device that's come to mind, which is a really good device, but not without issue. And the distal embolization, one of the main concerns. And because of that, we need to use a filter for distal protection, which adds some technical challenge and increase the overall cost of the procedure. So what do we want exactly when we are performing vessel preparation? A maximum lumen gain, no vessel injury, no residual stenosis, no dissection, no distal embolization, and of course, effective drug delivery. And a scoring balloon is a good device to do all these things. As we can see in this study, a systematic study, scoring balloon lesion preparation for DCB angioplasty, which shows the high efficiency of the scoring balloon for doing that. And the Tri-Wedge balloon is intended for stenotic lesions in SFA, popliteal, iliac, distal arteries. Also is intended for parasite dilatation in dysfunctional AVF. And for us, the major advantage of this device is that provides the same expansion effect as a conventional balloon, but with the 57% less inflation pressure. And because of the scoring element, our position at 150 degrees all around the balloon, he provides the force concentration without causing an uncontrolled disruption of the atherosclerotic plate. And because of that, he is our first choice device for vessel preparation. So a case, a 50-year-old female, past medical history, hypertension and diabetes, medication, losartan, aspirin, and insulin. And the patient arrived at the emergency department reporting that she had been treating a wound on the hallux with alcohol for 20 days. However, the condition progressed with severe pain. So we proceeded with angiography, which revealed a critical lesion in the SFA and popliteal artery, as well as an occlusion of all distal arteries. And angioplasty of the lesion was performed using a 560 millimeters tri-wide balloon and a 460 millimeters tri-wide balloon. And the angioplasty of the fibular artery lesion was performed using a 3 millimeter conventional balloon, which was selected as a target for distal outflow vessel. And here's the final result, with excellent lumen gain, no dissection or distal embolization. We proceeded with angioplasty using a DCB. So in this image, shows the capability of the tri-wide balloon for vessel preparation and free us for stent placement, even in a advanced disease like this one, as I show. And now I will talk about another device from Brosmed, a teach high-pressure balloon. And as we all know, the high-pressure balloon is an excellent device for stenotic lesions in arterial fistulas. And the teach balloon demonstrated significant superiority over the conventional and the other high-pressure balloon. Its low compile ensures the minimal control of the expansion up to the rate burst pressure of 24 ATM. And additionally, while it's a flexible tip design and the low tip profile facilitate the crossing stenotic lesion, minimize the potential vascular trauma, as we can see in this image, the comparison between the yellow and the teach high pressure balloon and the other high pressure balloon, the blue one. So another case, 65 years old female, hypertension, currently disease since 2021, atenolol, losartan. She had been using a brachycephalus AVF fibrillary. However, in the recent hemodialysis session, she reported increased difficulty in achieving hemostasis at the impulsion site, along with a reduction in the true intensity. On the physical examination, the true at the proximal segment of AVF was weaker compared to the previous, and the localized hematoma was observed at the puncture site, as we can see in this image. So we proceeded with angiography, which revealed a critical lesion near the anastomosis, and the balloon angioplasty was performed using a 7 millimeters teacher high pressure balloon. And we had almost the complete lumen gain and no fistula rupture, which enabled us to perform a definitive therapy using a DCB. So in the conclusion, the tri-wide scoring balloon and the teach high pressure balloon are a viable device for vessel preparation. They provide increased force concentration without causing controlled disruption of the atherosclerotic plate or rupture of the vessel itself without inducing a vascular injury. Thank you for your attention.
Thank you for a nice presentation. We have some minutes to discuss about this. I'd like to ask to you, maybe it will be a final question, using for the patient to have AV fistula, you can freely use through the AV anastomosis site using the scoring balloon.
Yes, I in some case I use the scoring balloon too, the tri-wide balloon for fistula, and I didn't put in my presentation because the cheek balloon. I chose for distal arteries, but I used to.
Yes. It's time to wrap up these sessions, and thank you all our speakers for sharing your valuable experiences and practical insights on PTA balloon procedures across different vascular disease. I'd also like to express my gratitude to our global audience for your active participation. I believe today's discussion have broadened our understanding and will help improve patient outcomes in our daily practice. We look forward to seeing you at our next webinar. Until then, stay safe and stay connected. Thank you, everybody.
Thank you.
Thank you.
Bye.
Bye.
Thank you very much.